this morning.
I
I would love to
Yeah.
know
We get the
sorry.
wrong stupid training. How much
Oh, I think somebody's
Yeah.
muted.
Yeah, just a reminder to keep yourself on mute if possible.
I would love to know who's in the room and who's in the Zoom with us today. So if you can, in the chat, put what your background is, your profession, if it's the organization you work with, but in particular, I'm curious, who we have in the space. Are you a therapist with children? Are you an attorney? Are you a public health researcher, et cetera? And that'd be really helpful. So I'll just open up the chat and see who we have. Family navigator and a mother, doula, perinatal coach, lovely. I'm also a doula, so lots of love to doulas. MFTs, adolescent family life, OBGYN, early start, early intervention. I think it's really helpful because we always, oftentimes have really diverse groups of people, which gives us a sense of examples to use. And also, if we were all in a room together, we'd be looking around kind of like having a sense of who was there. So I always think it's helpful for us to find ways to connect with each other. Just a dad, I love that. Parent educator, okay, perfect. So we are certainly all folks that work a lot with children, a lot with families. It looks like a lot of direct services. I'm seeing a number of people who probably do in-home. That was one of my favorite things to do for many years is in-home therapy and any in-home services. I mean, even as a doula, of course, we do a lot of in-home in that capacity. And you always, it's so different than being able to have a context for people when they're in their own home environment than it is when they're coming into, the other environment, if it's an office or a community space. So I really value, the efforts that people take to have careers that do in-home for organizations to really center that, because people really benefit from in-home services. All right, so thank you for letting me know who's here. So, in this topic, perinatal mental health and, thinking about ways to support pregnant and postpartum clients and their families, it's really helpful to understand some of the context of just general maternal disparity, because a lot of the elements of stress and potential trauma, unexpected incidences, the sort of like entering into this world of, the maternal space that can really turn people's lives around, is also centered around some of the disparities. So it's helpful to know what groups tend to have disparities and what types of disparities exist. So one of the important factors in the United States and California is that we have a huge disparity in mortality and morbidity for African-American families, Indigenous, American Indian, Alaska Native individuals as well also have a higher rate of dying from pregnancy-related causes than white women. There is a really strong concern around hypertension, around embolism, around hemorrhage. So we're talking about strokes, we're talking about cardiovascular related challenges, which certainly can be heightened if people have already, previous risk or, and that is within their own medical history. But it's particularly just pregnancy induced for a lot of people. So in the onset of pregnancy, they were healthy, and then they become pregnant and have, really chronic conditions that can potentially lead to, very difficult and challenging deliveries, sort of emergency C-sections, and the risk of death. And then ultimately some people do die as well, among other causes. There's also, a really strong concern around the racial disparity, especially when, sort of historically, people saw racial disparities as really related to the socioeconomic status of the community. And so for the African-American community, people said, okay, well, we have a high disparity with Black maternal mortality. It must be because there's a higher rate of poverty, because people are not, parenting as couples, because there's drugs, like all of the, leading stereotypes, but also some of the challenges that you'll see within various populations. So then they would say this about, a particular, immigrant population is because of this and that. But what we actually find, particularly to African Americans, is that when they actually have, take a sample of white women who did not complete a high school education, and they compare them to Black women with a graduate level education, they still have the same, a very similar disparity as the general group. And so Black women in those studies were still more likely to die, or they had higher statistics of mortality and morbidity. So, challenges related to pregnancy and childbirth than white women. And so we know that there's something more to these health disparities than just race, for sure. We also see a difference between African Americans, those that are multi-generation born in the United States, than those that are Black immigrants, for instance, Caribbean folks, people who are born on the continent of Africa. They see about 10 years that you get to sort of keep having, and this is among all immigrant populations, that you tend to still have similar health outcomes to your, original population for about 10 years. And then there's a weathering effect of being in America, the stresses of life, racial, disparities, hostilities, the challenges that are particular to the racial groups in the United States become challenges as well for those that would otherwise be represented within that same ethnic group or population. And so we know there's something that happens here in the United States, and we see this with all populations that are immigrant population, first, and then seeing a multi-generational effect after people, are sort of, acculturated to the American system, that they tend to lose some value that's been gained in the cultural pieces, particularly around maternity care, around nutrition, in ways that really are telling regarding what our challenges are here. We have also a rate that's higher for Black women to have C-sections. They're less likely statistically to have a successful VBAC. And this is really concerning because C-sections actually are 3 times more likely to cause death. Obviously not, C-sections are life-saving measures often, but comparing C-sections to vaginal birth, you're potentially 3 times more likely to die with a C-section than you would be with a vaginal birth. And so it shouldn't be taken lightly when C-sections are happening, but they're happening more often in certain populations than others. There is something called the Latina paradox, or the Hispanic paradox, that is really important to note, that what we find, particularly among Mexican-born women, is that there's a protective factor, which I was, speaking to a little bit earlier, where even though within the Latinx community, there's a lot of comparable social determinants and socioeconomic challenges in relation to the African-American community, there's a paradox that there are more favorable outcomes for Latina birthing community. And we're really seeing this as a result of these kind of informal systems of care for the mother, these, traditional value around taking time after the childbirth, the way that mothers and pregnant people are really centered by the family, by the community, in the religious space, that really creates a protective factor that other communities may lose because they don't have, the same sort of cultural influencing. And we see this very typically among a lot of immigrant populations, and why we have a particular Latinx paradox in the United States, in particular in California, is because we have this sort of constant influx of immigrant communities. So you have the opportunity to maintain traditional values, traditional support systems, traditional healing modalities, where a lot of immigrant communities will lose that in one generation and never have an opportunity to recover any traditional really protective factors. And so we're really looking to center, to encourage, to motivate communities to not lose any really valuable traditional practices as the generations, sort of evolve. And it's really important, particularly to maternal health. And that includes obviously both mental health and physical health, because if you have physical challenges, if you're, sort of pregnancy and early childhood, early infant experiences with your children are laden with challenges, with having to go back and forth to the doctor, then obviously you're going to have more stresses. It's going to put a lot more strain on the family, and mental health can also be a challenge there. We have infant and breastfeeding disparities in the United States as well. Preterm birth is about 50% higher for Black infants in comparison to other populations. Indigenous communities also have a higher rate of preterm birth. Puerto Rican communities, which isn't as high in California, but just nationally, tend to have more increased preterm birth than other Latinx community. This is significant, the preterm birth rate, because infant mortality is also 2 times higher for Black infants and Alaska Native, Indigenous infants as well. And the relationship between preterm birth, if a baby is born too soon, too small, they tend to not thrive, and therefore there's a risk of death. And so we have around about 50% there with death, related to complications of preterm birth nationally. One of the benefits, or one of the protective factors against, mortality for infants when they are born preterm, is to have access to human milk. And so when we see breastfeeding disparities in communities, or we see immigrant communities that started off with strong breastfeeding rates declining as they acculturate and the generations, adjust to American life, there's a concern there, because we really know that when possible and where possible, breastfeeding is a protective factor, not just in general, which is true for infants, for illnesses and things like that, but it's particularly protective if you have any challenges with prematurity in a community. And so we really want to see that be high. And, in particular for the African-American community, it tends to be lower than other communities. Right now, the Hispanic Latinx community tends to have a pretty strong statistics around breastfeeding. But what's challenging with statistics is that it's not really accounting for, you might get an average because you have an influx of, a more recent immigrant community that maintain breastfeeding, but then you're also not accounting for areas where you're not just sort of like taking statistics and putting people together. In certain areas, people may not be breastfeeding as much as others, despite the sort of national and sort of regional statistics. So this is also really important to be, paying attention to what the trends are locally to where you are, as we think about the benefits with secure attachment, as we think about the benefits to mothers personally for their own health. We know that breastfeeding tends to have protective factors against breast cancer, and also at times, depending on the nature of the perinatal mood and anxiety disorder, breastfeeding can also be protective against mood disorders as well. And then when we're looking at, the opportunity to have the mitigation of some of these infant mortalities, if you are breastfeeding initially, that's great, but the longer that people are able to breastfeed, if they're exclusively breastfeeding, particularly for small infants, their digestive system is not developed yet. And so having access to human milk or breast milk from, the mother, or donated milk is really valuable for a lot of that development in those times where there are challenges with the infant. So when we think about, maternal mental health disparities, there have not been really excessive studies that look, cross-culturally, cross-ethnically. There tend to be general studies that will just sort of pick out, but it's really valuable to go into more detail, because cultural groups are too diverse to just say the Hispanic group, right? Then we're like, well, who are we talking about within that population? And as all the populations are extremely diverse, even when, Native Americans and indigenous communities are not often caught in a lot of these statistics. And so we know that we're really missing a lot of information. But what we do tend to find is that Black women tend to have higher rates in the studies of perinatal mood disorders, particularly in the sense of when there is a sort of a focus group and people are accounting for how they felt while they were pregnant, accounting for, potential mood disorders in the aftermath. So not that they're necessarily diagnosed as often or more, but they are experiencing that and reporting to have experienced what would have been considered a mood disorder had they been assessed. And it's important to note that because we're actually missing a lot of gap with, Indigenous, with African-American and with Latinx community to actually assess and to screen so that we really know true and accurate numbers. When we are looking at treatment, we're also knowing that because there is a lack of diversity within the therapeutic, offerings of the community, there are certainly organizations that target, ethnic minority populations, but what we really see is that the providers themselves are not often reflecting the community. And so with the taboos of mental health, with the discomforts that people feel, and even the fear around whether or not reporting that they're having, emotional challenges, that they're, feeling stressed, that they're feeling like they can't handle life on their own, that they are in fear of their children being taken away, that they're in fear of, being reported to Child Protective Services, of being seen, in a negative light. And so people often will shy away from going to providers that don't represent and reflect their community. What we also see is that when people don't have access to, therapists and sort of like culturally congruent providers, there also is a sense that there's something othering about the experience of having mental health because it's not available in their community. And so, it must be so bad that I have to go all the way over here to get help rather than something that is sort of organically experienced. And so we know that that's some opportunities to create really strong development of the student population, the graduate population from communities that are otherwise not represented would be helpful. And in the meantime, obviously cultural competency training and really reflecting, cultural values and images within messaging and all that are really important. And we'll talk about that a little bit more. People also are reporting in focus groups in studies that they will see a therapist if they are able to get treatment, but that they experience some kind of inadequate or culturally incongruent or incompetent treatment, whether they felt disrespected, whether they felt that the therapy didn't align with their community and spiritual and personal beliefs, or something about it made them feel that they wouldn't be heard and understood within their cultural element. And so people then do not continue. And so we know that we really need, really strong cultural competence and congruence in the elements around therapy. And we'll get into some details about that, just sort of thinking about that high level. Some operational definitions. When we're talking about maternal mental health, I think it's really important to think, in the spectrum of mental wellness, emotional wellness. We're thinking of from mental strain to mental illness. We're thinking about self-reported sense of emotional well-being. Is the person saying that they feel good today, that they feel motivated, that they feel like they're on top of, their pregnancy, that they feel like they're maybe exhausted, but I'm doing okay. I'm getting through the day, and they're smiling and they're giving stories about, funny things that happened in the day, and sort of acknowledging the true reality of the strain on the physical body especially during late periods of pregnancy, or if they have difficulty during the pregnancy with nausea, and in the postpartum period. But this general sense of well-being that really gets picked up typically when you're, engaging with family members who know them very well. You want to be gauging how are they feeling like this person is doing based on their experience of their normal moods, because a lot of times we don't have a sense of what it means to someone else to say, well, okay, I feel like I'm doing okay. And so particularly, if you're in an in-home environment, you have access to family, it's really helpful to get an account, particularly around new parents, that everyone around them, or that the closest people around them also feel confident that the person is doing well. It's not 100%, but it tends to be a little bit of a protective factor against people wanting to show that they're good, because there's, of course, this pressure for a new mother and a new birthing parent to be good, to be comfortable, to be happy, and maybe they're struggling and they don't want to express that to you, but you can sort of gauge that with the family as well. Strength-based versus deficiency-based. So thinking about mental wellness, having conversations about maintaining mental wellness rather than just focusing on maternal mental health and giving people sort of guidelines around, well, you're really struggling if this. While that's helpful, it doesn't actually put them in a mind frame that they're trying to maintain, an elevated, not always an elevated mood, but as much of an elevated mood as possible. And so what we find is that people tend to be more encouraged to do things that are leading toward good feelings than sort of preventing bad feelings, especially because of the level of anxiety that people have often while they're pregnant and when they have a new baby. There tends to be a lot of focus on this could go wrong and this can go wrong and this can go wrong. And so doing your best in the communications with them and messaging, that's both in your social media messaging, it's in the messaging of pamphlets or handouts, but also in, a therapeutic or, conversational case management, really thinking about the strengths-based options for that individual. And we can get some examples and talk about that in a bit. Considering the relationship between the mind, like their psychological well-being, like, so we're thinking about memory, we're thinking about, their general sense of focus, those kinds of questions around like, how is your attention these days? Body, are they having aches and pains? Is there an over expectation for difficulty in the pregnancy? Like, are they, well, but I'm pregnant, so, it's always going to be. And it's like, well, but let's address that, right? Because we don't want to minimize body concerns because they're often cues that there's something happening. And sometimes it is just the reality of the physical body. If they're, in their 9th month and they're, really feeling heavy and they're, sort of achy, limbs, that may be within normal limits. But if they're in really strong pain and they think to themselves that they're supposed to be because they're so pregnant, for instance, you want to just really monitor like what is normal pain, normal discomfort in pregnancy and in the postpartum period. We've seen this, and I see this as a doula a lot, where people maybe expect to be bleeding. They're like, oh, well, they said I'm going to bleed, but they're bleeding way more excessively in the postpartum period than they should be. And so really just making sure that there is a mindfulness for like, what are the normal ranges there? And obviously you may not have that competency. So then it may be talking to them about, are you connecting, what does your provider say about this level of pain? Have you asked your doctor if this pain is normal? Things like that to really prompt for an intentionality around like feeling good in the body and in the mind. Spiritually, religiously, are they feeling connected to their, communities? We know that spirituality, just an internal sense of connectedness to whatever, if people are faith-based, or their own sense of, sort of inner knowing. But it's really a really strong protective factor, particularly around suicide and around, depression, to have, the activation of faith-based opportunities to not say just intervene, but to be incorporated in mental health, sort of treatment or approaches, because people within their cultural community really have buy-in to their spiritual or religious beliefs. And so if you're finding ways to incorporate ideas, concepts, values that are within something that's really congruent, as spirituality and religion tends to be for people, you really get a lot of buy-in for, maintaining, interest even in mental health, because it aligns so closely to what they already find to be, hopeful and encouraging. And then we have, psychosocial adjustment and concerns. We certainly know that pregnancy in the postpartum period creates a lot of scenarios with finances, with, relationships that may shift people's normal lives, and that can in and of itself be a challenge. And so we're often looking to see, are we just dealing with someone who's having an adjustment issue just related to the pregnancy and the postpartum, or what's happening in their lives around that? Or is this something more organic? Is this something that despite a situational change, it continues? And so when you see through the phases of the months that they continue to have a similar challenge if the event of something has been resolved, but also people need a lot of psychosocial support when they're pregnant in the postpartum period. That alone, the stress of, an extreme financial change, the uncertainty around jobs, particularly for, the birthing person, if they are not going to be able to go back to their job in a timely fashion for the job, or there's pressures. A lot of times, I always really encourage people to check in with their clients around the conversations that they're having with their human resources department if they're working. Because a lot of times people don't feel confident that they have a right to take off. They don't know the law. They don't know that there's protections for them if they're breastfeeding. And many people don't know that, right? And so this is also then an opportunity, if you're working really specifically with pregnant and postpartum people, to be activated in some of the advocacy and the policies around protections with employment, because we really see a lot of strong stressors with families around their jobs and their pregnancy, which can create in and of itself a level of stress that can cause people to have mental health challenges. And then, we're thinking about daily stress, like outside of being pregnant and postpartum, because that tends to be the main conversation. Oh, your baby, oh, this, but it may be that there's something completely different and happening in their lives that is not being addressed because they're pregnant, because they're postpartum, and everybody's thinking only about that. So just being mindful of making sure that you're also checking in with them around other types of stressors, and giving them space to talk about things that are outside of pregnancy and the postpartum period, if it's relevant to them. Prior mental illness, really important to assess that. That tends to be something that's assessed, by the doctor. Within the mental health world, we're pretty good about, looking for previous mental illness. Some things to think about is they may not identify that the fact that they had depression as a teenager could be still related to the fact that it's, they could have a potential sort of relapse of depression, in the postpartum and the pregnancy period. And so really making sure that you're clear with them that when you're asking about previous mental illness is like any time, whether when you were a child, even if it was just, obviously most people will think, well, in a previous pregnancy, I've never had depression, but I did have, some anxiety and depression with my first child, but then it resolved after. That also is, an indication that there could be some risk there as well. But you can also have a person that just has a history of depression that then they become pregnant and it gets worse, right? And so if you're not, if you're the therapist, then we're, thinking about, sort of diagnostic differences. But if you're just working with them, outside of, sort of trying to identify, you're really wanting to know if they had a previous mental illness that is now being exacerbated, or if it's a perinatal onset, like it's just starting and they never had any challenges. What's helpful about that is that it's good information to make them aware of as they're talking to their providers about what's happening, like kind of coaching and helping them navigate like the healthcare system. If they move to the next referral, that they're able to communicate really clearly that they, that this is the first time that they've had these experiences, but also that it's potentially chemical in nature and in relation to the actual pregnancy and the postpartum, and potentially not something that was underlying. All significant, but just, sort of diagnostically and in treatment can be helpful. Perinatal mood and anxiety disorders, I think I used that term earlier. Sometimes, it's called PMADS. This is a term that we used to call, people used to refer to it as postpartum depression always. And so then you were sort of missing the fact that there was anxiety, that there's also potential, post-traumatic stress, that there's potential for, obsessive compulsive disorder. So there are a lot of different types of mood and anxiety disorders that people can have in the perinatal period. And so it's a larger term that, tends to be used now. So before we get into some of those, I want to pause and see if there were any questions, any thoughts, any what came to mind, clients that you've worked with, we can have a dialogue and then come back to that, to this next slide. I'll give you a moment. Often people need to just think. Thank you, Meg, regarding the focus on wellness versus what can go wrong. Yes, we will be talking about how partners of pregnant people might be impacted by the perinatal period as well. Did you have any specific thoughts or questions about that, Heather? If you did, I'd love to hear them. You didn't have to. Okay. Now my mouse isn't letting me move. There we go.
Hi, my name is Reagan, and I have two thoughts.
Okay.
And one thought, you were talking about the lack of healthcare providers for Black women and being able to have, diagnosis or understanding that mental health. And I just want to say that as a Black woman, I understand and I can relate to that. Just with some of the patients that we've worked with and trying to find them providers, and some of the women specifically asking for Black women and having to do a complete search, even on on therapy for Black women, therapyforblackgirls.com, and finding providers who accept their insurance. And so that's been a really big thing, a lot of the patients that we work with in our community have Medi-Cal, IEHP, and being able to link them to a provider who's a Black woman. And it's not that anyways, being able to link them to a provider has been really, has been a challenge. And then two, and on just talking about some of the stressors, the formula shortage now has been a really big stressor for a lot of our moms, that with all of the stressors that they have, having to deal with the formula in its own and just being able to provide a basic need for your baby is a really big stressor. And so thank you for highlighting that for us, because it just makes me think of some things that when talking about our moms and the stressors that they have, and acknowledging that this is a big stressor, also realizing that that mental health piece is a part of that too. And we don't even get to address some of the stress, the other daily stressors that they have.
Thank you for that. Really thoughtful. Yeah, this, as you were talking about finding a provider and also one that has the same insurance. One of the things that we've been trying to do, one of the programs that my nonprofit has in partnership with is with Frontline Doulas, and it's a community-based doula program. And we do a lot of supporting community-based doulas because we see that, just having people connected to the in-home, connected to the family, being able to navigate in and out of different spaces, but also outside of the insurance system, only for the sake of it gives them options, not as a limitation, is really valuable. And so one of the things that we've been trying to do is see how we can get more mental health support for the Black families, because we have a program that provides free doulas to Black families. And where we have found success is linking them to, sort of like cultural spaces that are like support for the postpartum period. So there are more groups that are sort of like postpartum mental health groups. There's a lot of things online, in these virtual groups. And even though it's not ideal if you have a person that needs like sort of direct therapy, it does create a sense of normalcy and, encouragement, options for, like what they could do with their situation, because they're hearing other people. And there is some benefit just to that human camaraderie that groups give, that we do find to be helpful. I don't want to say as a Band-Aid, but as a part of mitigating, maternal stress and maternal mental health where it shows up. Again, not ideal. We would love to have, trained therapists be able to access and the families have access to folks that they feel comfortable with. And I will give at the end a resource guide for how to find therapists, particularly some resources for finding Black therapists that maybe you could also check in with and other folks can see, just ways to navigate that. I also always tell people that, you know, the number on the back of your insurance card, which people tend to like Google first rather than like go directly to their insurance. And because you could start to look for someone, and then if they don't qualify for the insurance, then it's very disappointing. But typically the mental health number on the back of the insurance card, if you call them, there is some within some limits of them needing to give you a referral. And so you could also start there. We're advocating for, I'm looking for an African-American therapist in this near the zip code, and then really having them try to curate. I've had some success there where people were trying to like look outside first, and then you know, sort of getting the insurance to do a bit of the work. So that might be helpful. And as far as the formula shortage, you know, I think I was in a conversation, you know, yesterday in Sacramento with like a bunch of public health folks and people just trying to figure out how to navigate that. So a lot of people are experiencing that, people are feeling really strong stress related to that. And I think, you know, this is one of those opportunities where coming together in a community may actually be more immediately helpful than like the larger system has to figure it out. But these are the times where if people have access to like collaborating within the small community, like who locally, a church, a center might have access to formula. Are there, you know, in the emergency scenarios, lactating, you know, women and birthing people that have extra milk that could, you know, help supplement for other people. You know, it's like very micro, but I really do hope that, because I've seen scenarios where people are sort of strategizing like through social media and through like outside of just systems, because the systems are struggling to like get to the individuals. And so just thinking, I'm thinking a lot, just like every day, about how can we galvanize the community to support itself, and to be trying to find solutions within the community where you have more access to information than people feel like they have right now. So yeah, we can always, you know, think about that more, and hopefully it resolves itself as soon as possible. Let's see, I saw someone else had something I was going to note. Yes, we're going to have resources. We're going to talk about assessment tools. Can you, Nini, say more about your question? I'm not clear about the question. And I'm just reading the rest of them over here. Okay, yes, I also have seen a number of Facebook groups that are great. And I'm going to share a couple of online groups for you all to recommend to folks, that lactation groups, new mother groups, groups that are specific to, you know, cultural populations, you know, queer parent support groups, single parent support groups, like really gets fine detailed. And gosh, with technology, we're so blessed to have options there. Okay, so a little bit about how stress affects the brain. And I think, you know, this really leans to sort of like underneath why some of the roots of mental health and maternal mental health are occurring. So just going to show a video clip.
Are you sleeping restlessly, feeling irritable or moody, forgetting little things, and feeling overwhelmed and isolated? Don't worry, we've all been there. You're probably just stressed out. Stress isn't always a bad thing. It can be handy for a burst of extra energy and focus, like when you're playing a competitive sport or have to speak in public. But when it's continuous, the kind most of us face day in and day out, it actually begins to change your brain. Chronic stress, like being overworked or having arguments at home, can affect brain size, its structure, and how it functions, right down to the level of your genes. Stress begins with something called the hypothalamus pituitary adrenal axis, a series of interactions between endocrine glands in the brain and on the kidney, which controls your body's reaction to stress. When your brain detects a stressful situation, Your HPA axis is instantly activated and releases a hormone called cortisol, which primes your body for instant action. But high levels of cortisol over long periods of time wreak havoc on your brain. For example, chronic stress increases the activity level and number of neural connections in the amygdala, your brain's fear center. And as levels of cortisol rise, electric signals in your hippocampus, the part of the brain associated with learning, memories, and stress control, deteriorate. The hippocampus also inhibits the activity of the HPA axis, so when it weakens, so does your ability to control your stress. That's not all though. Cortisol can literally cause your brain to shrink in size. Too much of it results in the loss of synaptic connections between neurons and the shrinking of your prefrontal cortex, the part of your brain that regulates behaviors like concentration, decision-making, judgment, and social interaction. It also leads to fewer new brain cells being made in the hippocampus. This means chronic stress might make it harder for you to learn and remember things, and also set the stage for more serious mental problems like depression and eventually Alzheimer's disease. The effects of stress may filter right down to your brain's DNA. An experiment showed that the amount of nurturing a mother rat provides its newborn baby plays a part in determining how that baby responds to stress later in life. The pups of nurturing moms turned out less sensitive to stress because their brains developed more cortisol receptors, which stick to cortisol and dampen the stress response. The pups of negligent moms had the opposite outcome, and so became more sensitive to stress throughout life. These are considered epigenetic changes, meaning that they affect which genes are expressed without directly changing the genetic code. And these changes can be reversed if the moms are swapped. But there's a surprising result. The epigenetic changes caused by one single mother rat were passed down to many generations of rats after her. In other words, the results of these actions were inheritable. It's not all bad news though. There are many ways to reverse what cortisol does to your stressed brain. The most powerful weapons are exercise and meditation, which involves breathing deeply and being aware and focused on your surroundings. Both of these activities decrease your stress and increase the size of the hippocampus, thereby improving your memory. So don't feel defeated by the pressures of daily life. Get in control of your stress before it takes control of you.
Okay. One of the things I appreciate about that video is that it, ends on, while you have some, risks for disparities there, you have this really strong opportunity related to epigenetics to shift things with current day behaviors, mindfulness, activities, exercises, which is stuff that we can do with pregnant and postpartum people every day. We can do this with children. It's something that outside of the perinatal period really benefits people, particularly those that have families that have been exposed, historically to stress and strain, or the chronic stresses, not, yes, regular stresses, which would be good for everyone, but, really strong, sort of, historical trauma and, race-related micro stressors, and really can benefit folks to have the reversal opportunity going on related to epigenetics. One of the studies that I find to be really telling about the impact of stress on the body, long-term, of trauma on the mind and on the body, the physiology, is this study about the incidence of PTSD connected to preterm births for Black women. So the study actually looked at, hundreds of women of all different ethnicities. And what they found, what they were looking to see is what's the impact of having PTSD, a history of child abuse or personal abuse, and a diagnosis of PTSD at some point in your life, to having the risk of having a preterm birth. And they found that, yes, there is a risk. If you have, PTSD, you're more likely to have a preterm birth than a person that does not. What they maybe didn't expect to find is that there would be a really strong difference between the rates of particular ethnic groups. So Black women in particular were 4 times more likely than white women to be still affected by their PTSD at the time of delivery. And so they actually still had, they had more preterm births than the other populations. This is really significant because when we're looking at communities or people that are affected by multiple stressor, long-term potential traumas, so not just personal trauma, which all of them had incidents of childhood trauma in these studies. But we also know that certain populations are exposed to other types of trauma, and their family members have been exposed to stress and trauma over generations, and that this can have an impact. And so we're thinking about this for African-American populations, but we're also thinking about this for immigrant populations that specifically would have been from communities that might have had multiple generations of war trauma, of ethnic cleansings, where you would experience multiple generations, having trauma, and potentially, passing on genes that respond to stress in a very protective way for the first generation. So in the first generation, being hypervigilant, having a strong startle response so that you're attentive to the risk of danger is really protective and helpful if you're in a society where people are attacking you, where people could kill you, where people are maybe going to take your children, in all these varieties of ways that this could show up. But in the next generation, having, a hypervigilance and a high startle reflex, or, having any of the symptomology that's related to trauma that can be sort of, passed on through the generations, may not be as protective of a factor anymore if it's not as relevant, or it could still be, but then creates a lot of, potential for dysfunction in the body and in the mind. And so as a society, we always have to be thinking about the individual that we're looking at, but also what's the societal positioning of this individual, and how can societal positioning be stressing this individual more than the average person? And so what can we do to mitigate this? And we can really do a lot of stress reduction techniques, really incorporating not just talk therapy or, sort of models where it's very intellectualized, but a lot of things that are very also traditional: dancing, drumming, singing, engaging in community spaces. Someone's gone off mute. There we go. Thank you for muting. And so just being, mindful of opportunities to really have, if you don't have that as a part of your offerings, be connected to, partnered with folks that are doing really strong stress reduction techniques for this and all populations. Another really interesting example of the impact of stress and birth and the physicality is that there was in 2016, there's constantly, sort of like a checking in to see what are the rates of this population, or what are the rates of preterm birth this year. Preterm birth and maternal mortality are very well monitored. And so during this time, there was a huge rise in preterm birth among Latinas in the months following the election. And so what we know about that time is that people were really concerned, particularly in communities where there were high levels of immigrants, that people would be, unnecessarily or unexpectedly deported. There were raids of communities. The federal prison system incarcerated, thousands of immigrant community folks. And the Hispanic community was very, were overly, sort of represented in this. At the time, I was actually working in the federal prison system. And so I always find it interesting that I was right there on the front lines for that incident. And there were people from all over the world who were, incarcerated during these years. But certainly the Latinx community was really strongly overrepresented. And they found that there was a high level of preterm birth in these times where there was this tumultuous, specific targeting of a particular culture. We know that in wartime, in every place where that exists, if there's a war, if there's some really strong event, even during 9/11, those that give birth in the period of time in the wake after those events have happened, that preterm birth is higher. And so one of the connections between preterm birth and mental health is that you're looking at this stress factor. And so we're kind of in this like partnership, those of us on the emotional support side and those that are in the physical, and medical side, is that the more that we can minimize stress for pregnant and postpartum people, the more that we can, minimize, health disparity with infants and, and birthing families on the physical level. And then obviously mitigating the stress is also going to potentially mitigate mental health challenges as well. We also see an impact of stress on breastfeeding outcomes. So there was a study done in New York where they looked at various psychosocial stressors, financial, emotional, domestic violence, various like sort of traumatic stress. And they saw, not surprisingly, that traumatic stresses and stresses negatively affect breastfeeding outcomes. So people, if they're extremely stressed, are not going to begin to breastfeed. And they're also going to stop breastfeeding really early. And so one of the things that's helpful about this is that it cues you into, when you're trying to assess for if a person is struggling emotionally, one of the potential cues can be, if they were a lactating and breastfeeding person, how is that going? Because that is very much related. The body's ability to produce milk, to keep it flowing, gets affected by stress. Stress and mental health also affects sleep, which also affects, potential milk supply. And so the relationship between milk supply and mental health is really paired. And so when we talk about assessments, we'll talk a little bit more about that later. Any questions on that before we go into some examples about paranoia, mood, and anxiety disorders? Let me just check the chat. I will send, I can send the video. I don't know that it exists in Spanish by that company, but I can see. I will look for that. Somebody's noting that the Wix stores seem to have a good supply where they are. That is good to hear. Okay. All right, perfect. So perinatal mood and anxiety disorders. So we're going to talk about them in general. I'll talk a little bit about suicide risk factors. One of the things that I feel, really blessed to have been able to participate in the past and continue is the Maternal Mortality Review Committee for Maternal Suicide in California. And so there are committees that meet to review basically all of the deaths that occur related to maternal mortality. And so there was a separate mental health commission group, and we looked at the rate of suicide compared to certain, ethnic populations. But really what I found most interesting as far as like the clinical information, what can people know who are working with people, are the things that I'll share with you today. So when we talk about perinatal mood and anxiety disorders, so we know that we're, sort of checking to see if people have, pre-existing mental illness. So antenatal depression and anxiety, we're talking about during pregnancy, people have about 15 to 20%. There are 15 to 20% of people that have anxiety and depression during pregnancy. And this is really important because the old term postpartum depression was an extremely misleading term that we are now stop using, because people think they're only looking for it in the postpartum period and wouldn't be assessing and supporting during the pregnancy period. I mean, we know that that's not actually helpful. Postnatal depression, so after childbirth, is pretty much identical to what we're seeing in the pregnancy period. And so really, again, for screenings that they're happening during pregnancy, pretty much, you're wanting to assess right away if someone's pregnant, what's their baseline when they get pregnant, so that you can have a comparison when they're at 6 months, when they're at 3 months, when they're at 9 months. And really, I recommend that people, if they're working directly with them, either they themselves or within a group model, if you're working, within, sort of a group model where there's multiple practitioners working with them, that you know that somebody is actively and constantly assessing, not constantly as in like an annoying way if they say they're fine, but being mindful that it's not just like there's one time where we do it in the prenatal period and then, you know, this one period where we do it in the postpartum, because things can change, and it's helpful to have gauges. And I really recommend that people use a self-assessment so that they know for themselves how they're doing, and they can also be checking over time for themselves when that's necessary. And we'll talk about those specific assessments. We know that socioeconomic and life stress definitely have an impact on this. And so while it's 15 to 20% sort of generally, folks that have higher socioeconomic and life stressors are going to have more rates of depression and more risk. Postpartum anxiety and panic disorders is about 11%. And so this is, you know, when you're moving into, you know, really strong, you know, panic and anxiety disorders, you know, we're coming away from just sort of general worry and fear and concern to really active incidents of, and if you have not experienced someone with panic disorder, a lot of times it interacts with their physical body. People feel like they can't breathe. They feel like they, you know, particularly around, because the belly is often, you know, prohibitive for breathing at a certain point altogether, that people feel like physically they're not able to move in certain ways and they can still breathe. So they might say that they can't breathe when they're sitting up, or they can't breathe laying down. That there's a confusion about what's happening. So that's like one of those really like strong ways to figure out, is somebody having a panic disorder, like they don't understand what's happening to them. Where typically if you're having a physical ailment, you're aware that like, oh, my stomach hurts, or, oh, I'm having a hard time breathing. You know, like my chest feels tight. And it's very, I was just washing dishes, right? Like nothing was going on and now I'm having pain, versus, you know, I don't know, I just can't breathe and I'm not sure. And there's often a lot of like confusion that goes along with a panic disorder that kind of helps you if you're wondering like what's happening to a person. Looking for confusion paired with the physiological reaction is sometimes a very good cue. We're looking also at perinatal obsessive compulsive disorder. So when we're thinking about obsessive compulsive disorder, we're talking about having, you know, obsessive thoughts. You know, maybe there's something wrong with the baby. Now, what's interesting and really difficult about pregnancy in the postpartum period is that there's such normality to anxiety, to feeling sad, to feeling confused, to hoping that you're doing it well, to having concern for your baby. Like that's such a normal part of it that it's very difficult sometimes to differentiate. So I'm going to give some examples. What I'd love though is for those of you that work with folks to also chime in after I give these examples, and let's also give some examples to folks, because it's really helpful to hear different ways that people see this show up. So one example would be, this is within normal limits. You know, a person is, you know, just, I really hope that, you know, let's just think of the pandemic, that, you know, I'm protecting the baby enough when we go out. And so, you know, we're going to put a cover over the bassinet, and, you know, we're going to just doing like practical things, and then sort of laying it down and saying, okay, well, I did that. Okay, let's go to the store. Another person who is having extreme sort of like, now it's becoming obsessive and not just within normal limits, let's say, is it may stop them from going out altogether. It may stop them from wanting anyone around them to go out. So then it's like unreasonable that like anything could actually practically get done. They could be saying to themselves, okay, I think I put the cover on. Well, no, let me go back and check, because let me just make sure that this happened. Okay, well, I put the mask and I did this. No, I'm not sure. No, I don't know if I can do that, because so there's like a lot of second guessing. There's a lot of like going back to the same thought over and over again in a way that feels uncontrolled. So a lot of times if you ask the person, if I wanted you to just sort of like think of something different, like let's just change the topic, do you feel like that thought is going to just keep coming back to you? Or only when we're related to that topic, right? Only when you're going to the store that you're sort of having these concerns, rather than you're always thinking about this particular issue. The compulsive part is some kind of compulsive behavior that makes them feel that they can resolve this obsessive thought. So, okay, well, I'm gonna, I can wash the baby's hands again. Let's say I'm gonna go and wash my hands. That's gonna, okay, then wait, but I don't know, I might've touched something. But let me go back and wash my hands again. Okay, well, I'll just grab the hand sanitizer. So it becomes almost an uncontrolled behavior, right? And so then it's like this thought that keeps coming up, and then this thing that I can do to make it better, but then that in a normal situation would resolve it, but no, it could happen again. And so then there's this like active loop. So even in the way that I'm describing it, like it sounds like a lot's going on, and there's a whole sort of web that keeps weaving that never ends. And that's sort of like the feeling that you will often get if you are interacting with someone who's describing this behavior or you're witnessing it. It feels extreme and alarming or concerning or confusing to the person watching it. And so like as a practitioner, what I typically like to do is compare, like I'd like to know how people around the person who are used to them feel about the behavior, and their concern is very telling. So if you're ever wondering, I have, people call for a consultation and ask, like, I'm not really sure if this is okay, if this person is okay. How is their family saying that they're feeling about it? Oh, well, no, the partner said that they called. I mean, they were like, can you please come? I don't think she's going to be able to like do this by herself. That's really important information, because people around people tend to have a better sense of what is going on than you might if you don't know them well. Postpartum post-traumatic stress disorder. This is often related to some kind of birth trauma. So something that's happening in the pregnancy, something that happened during labor and delivery. Oftentimes perinatal loss and grief are related to this. So there's a loss of a child, there's a loss of an infant, there's a miscarriage of some kind of stillbirth. And in addition to that, there's some kind of traumatic event that they felt was traumatic to them. And I say that because, for a lot of people, the subjective experience of moving through, a very, complicated and like, catastrophic result of their pregnancy is laden with, I went in just to get a check, and then they told me there wasn't a heartbeat. And then, so then there's this like course of events that was very fast. They weren't prepared, which who's prepared for trauma? And they didn't have the ability to process the information. The care providers, they might have felt like they were insensitive. They might have felt that they were alone in the process. They might have actually been alone in the process. Like during the pandemic, lots of people actually had to go through the course of their losses by themselves because there wasn't access. And so really just knowing that there are a number of types of scenarios that can happen, whether it's emergency or not, it's really about the person's perception of their trauma than whether or not there was what has been like identified as a type of emergency. Because we also see this type of post-traumatic stress with people who had non-emergency but unexpected C-sections, for instance. So they went in for a vaginal birth and they were trying, they had been laboring for a day. And then, it doesn't sound like the heart tones are going well. And then they're recommending a C-section. It may not have been done in a fast and emergency way. They may have said, okay, well, we're going to give you some time, and we're, but still they felt that things were moving too fast for them. And I will also say, I've experienced that people who've had very fast vaginal births also have experienced post-traumatic stress disorder. So they, you think, oh, well, you had only a 5-hour labor. That's amazing. Congratulations. Well, if you've ever gone through a really fast labor, the whole process from start to finish still has to happen to your body. So it's an extreme body intensity for a very short amount of time. And a lot of times in those incidents, people don't feel like they had the opportunity sort of to catch their breath, literally. They just, immediately started feeling what feels to them like intense pain that didn't let up. And while they might have had what looks to the world like a successful birth, they felt really traumatized by it. So I always recommend that people let people, when they've had their pregnancies and their labors and their processes, talk about how it felt for them to go through the process. So like specifically, not like, oh, how was the delivery? Because most people think you're asking them, well, how did the baby come out, right? But really asking, how was your experience in the process of birthing your child? Like, what did it feel like for you? That's a question that most people are never asked. And the opportunity to process that way in and of itself tends to be really healing for the average person, but also can lift up the opportunity to hear if there was any trauma around that. And so what we're looking for when we're thinking about trauma is, you know, unresolved thoughts that, you know, they still are having that actually come up as like flashbacks, or I just keep thinking about this one thing. So sometimes I'll ask people, is there anything that sort of has stuck with you in your child birthing experience that you feel like you just don't understand, or feels unresolved, or you were confused about? And then they're like, well, yeah, actually. And then, or sometimes they're like, yeah, you know, like they right away they can identify it. And so you could see to the level of trauma versus stress versus just an unresolved difficulty, but really important to really query for that as much as possible, you know, with the appropriate person. And if you know that you're not that person, see that there is a person in the team that can support them that way. Then we have postpartum psychosis. It's not as common, you know, 1 to 2 out of every, you know, 1,000 deliveries, but certainly that's still a whole person every 1,000 deliveries that potentially is hearing voices, is seeing things that other people don't see, is having delusional beliefs about themselves, about the baby, about the environment that is really scary, that's very anxiety provoking. That really is a psychiatric emergency and requires support. And there are cases that we've seen in the maternal suicide review where this was missed, that the person was having psychosis, because they appeared to be very functional, like they were still cleaning up the house and they were bathing themselves and bathing the baby, but they were having really strong delusional thoughts about something in particular. And so just in general, I mean, it's, you know, without having, you know, like advanced clinical skill and looking for psychosis, you know, for those of you out there that that's not your background, just knowing that if you ever are in the presence of someone things that other people don't see, that they have beliefs that are what a normal person within the realms of the conversation would say were irrational, it doesn't make sense, that they need an immediate referral to someone to assess them. And it usually requires an immediate support, and often medication is utilized, but there certainly needs to be an intervention there. And so just, you know, just knowing that that is, you know, that's an emergency. And then, you know, when we talk about perinatal and maternal suicide, we're talking about 5% of the population that have any perinatal mood disorders, not just 5% of all birthing people. And so while it's a small percentage, we still want to save all people's lives and catch everything that we can. A couple of high-level things that we learned in the Maternal Mortality Review Committee for maternal suicide. There was typically people think that, you know, postpartum mood disorders are like something that's going to happen like within the first 6 weeks or maybe within the first 6 months. And so people tend to not be, I mean, all the doctor's appointments tend to be done. I mean, we're just now with a lot of the recommendations that those of us in this work have been doing to like say, actually, no, we need to keep seeing people for a year. 6 months is not enough. Some people are arguing for 18 months. But the higher percentage of maternal suicides actually happens after the first 6 months. And so that's really a concern, because this is typically when all the family is gone and everybody's like, oh, well, mom's doing well, the baby's doing well. And so people need to be checked in on. There needs to be like a close assessment of this person who's birthed, who's had, you know, a really strong physiological and chemical shift in the past 6 months, to be followed up with and checked in on their wellness around that, you know, perinatal experience, you know, ideally at least up into a year. And so if you are seeing a patient, you know, who, even if you're working with a young person, like, you know, a toddler, but the person has, you know, well, you know, you're working with a family and the mother has a baby, you know, that's 7 months, and you're just sort of checking in, check on those mothers as well. Let's not forget about those that have babies that are over 6 months. They're still really in the postpartum period. They often are forgotten. And so, the higher risk can happen there as well. Something about supporting higher risk individuals. But actually, I'll pause there and see if there's any questions about some of the examples.
Can I voice out a question?
Yes, please.
I'm one of the things when you were talking about psychosis, one of the things that came up is I've heard a lot of moms mention like a loss of memory after birth, after giving birth, or even a lack of oxygen to the brain because of the pressure they are giving, that it's happening to give birth. And I'm just wondering about your thoughts around that, or even just how to support moms in those instances. And the loss of memory actually continues for quite some time. And just they feel, sometimes they'll express feelings of dizziness, like right after giving birth, and even continuously, or just a little bit of dizziness, as if there was a lack of oxygen to the brain. So I just wanted to see if you had any thoughts about that.
Did you, in those cases, are those people that you feel like they experience like a traumatic experience in that?
No, they were regular births, no C-sections, but they were without the medication.
Okay.
Mhm.
Okay. Without the epidural. So, memory loss in childbirth is common in the sense that there's so much intensity, there's so much happening, the course of time gets lost. Like the brain actually really allows you to just sort of stay with the sensations that are happening without tracking the time. Because if you are really conscious of, I am now at 24 hours of doing the same thing every 5 minutes or 10 minutes or 2 minutes, it'd be overwhelming. And so there is sort of a general, I think, protective factor in the process of childbirth where there's a forgetting of details. And so you will find that people in a normal scenario where they don't necessarily feel that they experience trauma, that they will recount something that happened in an order that's not the order it happened. Like everybody else who wasn't having the baby is like, no, this actually happened first. And they perceived it happening all at the same time or at a different time. So memory lapse isn't like completely unusual, but I would say that it would make me wonder if there was any trauma or that they experienced some kind of like dissociation, let's say, because there was something happening that was too intense that they sort of were checking out, which is possible. Now with the dizziness, I mean, there's certainly a lot of physiological reasons why people feel dizzy. They could have had excessive bleeding, or even just the general bleeding. People can feel dizzy after. It's a lot of intensity in the pushing. It's sort of the relief of having the baby and the physical changes that happen like instantly with the chemicals, and instantly when the placenta, is beginning to detach from the body, is like more chemical changes than you experience like in your entire adolescent, reproductive change. So it's really extreme. And it does cause a lot of physiological response. It could be sweating. It could be, a sense of like a loss of consciousness, but like you're awake, but you're like out of it for a while. And so that tends to be really within normal limits. As long as they're not feeling like there was something that they wanted to recover from that. Like if there was some trauma related to that, I would wonder if there was some like dissociation there of something that happened, because I do see that. Even if it wasn't like a C-section trauma, but like they felt like everything was happening too fast, or when they were in transition, which is like the period right before you're about to push, there's like an extreme psychological and physiological change that happens in the body as it's about to go into like really strong, like animalistic phase of like pushing. People feel out of control and overwhelmed, and there's like a flood of emotions. And typically people who are in the birthing space are like, we know where we are, we're transitioning, but it feels to them like something crazy is happening, right? And so then you could have that happen. So those are really good questions. And thank you for that. Mm-hmm. Other questions? I saw some things in the chat about the frontline doulas. I will talk about some resources where people can access frontline doulas locally. About pregnancy mentors. Yeah, really important and helpful. I do have screening questions that we'll share as we get to the next part. Okay. Okay, perfect. So some things about supporting higher risk individuals. If they have a history of previous, any kind of mood disorders, especially if they have a history of having had it in a previous pregnancy, if they have had, if they say that like when they get their period, so menstruation, extreme mood changes is also really telling for the potential to have perinatal mood anxiety disorders, because it's telling you that when there's a strong chemical change related to the reproductive area, it shows up as strong mental health challenges. And so this is really important to note those like three things, like previous, mental health disorders, previous mental health challenges in a pregnancy prior, and any kind of mental health, like extreme anxiety, extreme depression. I can't get out of bed. I don't go to school or work. I'm completely non-functional. I, feel manic, during period and premenstrual periods, those are really good cues. So you want to, sort of be like thinking about not like having them feel like they are at higher risk and that they should be scared for themselves, but you as a provider and a person in their support team need to be paying really careful attention, make sure that screening is a part of the process for them. When I say prepare, I think it's really important for folks, if they've ever had a suicide attempt before, just in their lives, even if it was like for a different reason, if there's any concern around that, or that becomes a concern, they should know that what the resources are in advance. So it's not ideal once a person like develops a postpartum mood and anxiety disorder, or, during the pregnancy period, that they then start looking for a provider, right? Like we were just talking about how hard it is to find a provider, like on a regular day when you're just like, I really would love to talk to someone. People will have no energy to do it when it's time. And so it's helpful, as we're thinking about sort of like safety planning in that kind of way, to have the therapist, identify who could they go to if they have a problem. First of all, does their provider know that they have a history? Is their provider connected to resources that way? And for you, the person that's supporting, do you know the referrals directly yourself? Giving people warm handoffs is really imperative. I think for all people, but certainly for those that it's not culturally normative to go to therapy, like you really are, it's going to be a lot for them to want to then in their most vulnerable space, go to a system that they don't necessarily feel is congruent to them. And so having warm handoffs helps, because you can name the person, you can give a prep, you can say, this is the situation going on. They've asked for, support. They're going to probably call you next week. If you can make sure, you're doing that with the provider, if that's, within the limits of, confidentiality and comfort for the client, or at least you're explaining to the client the relationship that you have with that provider, or the experience that you have that they've helped other people. But just in general, finding ways to make it as warm as possible of a handoff is really is essential. Keeping resources on hand. So like if a person asks you about things, you can just give it to them directly rather than having to go look it up, because a lot of times they're just sort of like, people wait when they're like desperate and ready to ask for help. And then if there's any delay, there's often going to be a difficulty for them to actually secure that referral. Seeking out trainings like this and more trainings for yourself that really make you feel more confident if you're not a mental health professional already, or perinatal world is not your specialty, and incorporating mental health screenings. And that's what we're going to talk about next. And just in general for organizations, thinking about cultural competency, public awareness that's related to the cultural group, linguistically conscientious resources, not things that are just translated, but not also shifted to the culture that you're working with, having people within the culture or the community, like focus group, how does this pamphlet look to you? How does this read to you? Like really being intentional about including as much as possible community voices in the things that you develop. So some things to think about for screenings as we close. You want to think about the location, like where are you when you're doing these screenings? Like what's around? Is this really an appropriate place to ask people whether or not they've ever tried to hurt themselves, whether or not they're feeling like they're having thoughts of hurting themselves or their baby? Who else is around? Is the partner around? Is that a good idea? Do they feel comfortable? Is their mother around? Is there like, what is their comfort level? And really ideally assessing that in advance. Like I'm going to ask you some questions, like when you have them by themselves, asking them if they would like to answer those questions in front of someone else, if they would like to have them by themselves, but really being mindful, you know, the proximity to others when you're doing the screenings. And then the legal and the social system impact. So are you sure, like if you're a mandated reporter, which most of the people probably on here are, and the person, you know, says that they're having thoughts of hurting themselves, do you actually know the course of action that you would take with this person that has a baby that they're still breastfeeding, for instance? If the police came to take them away right now, or if, you know, they had to go into the psych hospital right now, what would be the consequence of that? So you really understanding like the full legal and like social parameters and risks, and playing that whole thing out and making sure that there's a lot of informed consent. And intentionality, like when people need help, they need help and we want them to get help. But I've seen a lot of people not have a plan and then sort of be in a situation where now they just like, oh, we're going to have to call 911 and then the police respond and then it's not a thoughtful response. And so, you know, just really leading up to that, but also letting people know like their rights, like this can't, if it is the case that a particular, you know, consequence is not going to be around their immigration status. People need to know that if they have challenges around immigration or concerns around that sharing this information with you will put them in, you know, a negative position for some legal aspects. Assessing your cultural proximity to the client, like, do they feel comfortable with you? And culturally doesn't necessarily mean you reflect their ethnic culture. It could be their gender. Do they feel like you are, you know, sensitive and understanding about their family dynamics, like thinking about all of that. We talked about normalizing earlier, but really important to let people know sometimes people have challenges. Sometimes, you know, your mood will change. Sometimes, you know, it's normal and important to know how you're doing and be able to gauge it. And so I'm not doing this assessment because there's something wrong with you. I'm doing it because I think it's helpful information for you and for me to know how to support you in this process, like that kind of messaging. There are a number of tools. I'm going to give you, you'll get this as a handout via email later. I would recommend, if somebody get asked about screening tools for folks, the Edinburgh is translated in the most languages. It's screens for both depression and anxiety, for suicidality, and also people, I find it to be more functional as people are trying to understand what's going on with them, because there are more options in that. It's simple, but you still might find that people ask questions as they're doing it, so you could be familiar with it. It's a self-assessment, which means that they're answering questions for themselves. If you give them an online version, like you text it to them, there's a calculator that will score it for them, so they don't have to do the math. That's really helpful. So I'll give you this so that you can have some options to kind of look at, but ideally I would say people use the PHQ-9 a lot. That's also great. But I tend to recommend the Edinburgh because I think the crossover for most people who are taking it, it's easier. One of the things that I wanted to say about the Edinburgh, this is just an example. It's like a sheet like this, or it's online with these questions. It's 10 questions. Most important, it's asking about the past 7 days. So you want to make sure they're clear that it's not like forever. It's just in the past week, because you're trying to assess like how they're actually currently presenting. The last question is the question about suicide, or kind of, you know, checking for potential self-harm. You want to be paying attention to that, right? You want to have, if you're like a supervisor, that somebody's monitoring these Edinburghs, that people are sure that they're, you know, making sure that there's no questions about that. And then I'll give you a whole bunch of resources one of the ones, just high level, Postpartum Support International, which I'm sure many of you are familiar with. They just came out, like as in like last week, a maternal mental health line. So they actually have live therapists that are on the phone now that can do like support with people rather than just a referral system, like a warm line, which they've had for many years, which was also great. They have a psychiatric consultation line. So most people's doctors don't actually have skills in perinatal pharmaceuticals. They're really trained for the non-pregnant and lactating person. And so their doctor can consult with a doctor for free on this line. So that is a really helpful resource to tell clients and patients that they could give this to their doctor if their doctor is unaware, or if they're concerned that they're not, that they're being like tapered off of something, but they feel like they need it. Sometimes people make bad choices, and we've seen that with the suicide committee, that people were taken off medications because they were pregnant, that they really needed their medications. Maternal Mental Health Now also has a lot of resources for providers such as yourselves. And so they have a lot of trainings and workshops that, and some handouts for families that I think are really great. There is specific resources for African-American women. There's one for perinatal loss. There's a podcast, which I find anyone could listen to. You don't have to be a Black woman, but really helpful for people who have lost to hear other stories of loss, so they can feel normalized. Like when they're ready for that, I've found that people really appreciate it. And then this is some online support groups for maternal mental health, specific to Black families, that, again, I'll give you these resources, just sort of like letting you see it. And a whole host of recommendations. But what I will say is that it's really important to center like the actual client and their family and their particular needs, their particular cultural perspective. Like we have a lot of mass systems that are trying to approach this in like a standardized way, which is really great and important to have standardized care, but there always has to be like a tuning back into the very particulars of the individuals, and being mindful not to become unbalanced with systems that don't necessarily work for them and systems that need to expand to really fit the population that we're serving. So I know we're at time. I thank you all so much for being here with us. And if you have any questions, I'm here for questions if needed.
Thank you so much. That was wonderful. Yeah, we have definitely some time if people want to chime in, either in the chat or you can unmute yourself. And if you have any questions or comments. And I will be sending out an email with some of the resources that were discussed today, as well as the link to the recording and any information about the CEUs that you can access.
Hi, it's Reagan. You mentioned frontline doulas. Is are postpartum mothers able to call frontline doulas for support? And
Yes.
is that up to a certain, how many months postpartum will you be able to provide assistance?
Yeah, absolutely. And thank you for mentioning that, because I wanted to say that. So yes, so one of the offerings is a frontline doula hotline. And so the hotline is Black doulas that are available. The hotline, it was specifically created for Black families. They are able to, they would take a call from a mom. If she said she was postpartum and she was 18 months postpartum, they would not turn her away. But typically people tend to, identify themselves as postpartum within the first 12 months. But there's no really strong limits to that. Their families, their partners, their parents can call on behalf of them. It just needs to be related to the person, that's having the baby or that just had the baby. People call about lactation, so that's available. And we're actually looking at trying to figure out just opportunities for the hotline doulas to have some resources as readily available as they come out for folks around the state regarding the formula issues as well, because we figured that people might call asking about that. And so we've been talking about that. So thank you for that question. I'm going to look at the chat for the other questions.
Hi there, this is Dr. Alvarez. I'm so sorry I'm in a healthcare setting and it's loud, but I just wanted to thank you for what you presented. I have been teaching about racial trauma and immigration trauma and how if we don't address that, it's hard to treat mental health issues separate from that. It was really powerful to see the data on maternal and infant outcomes related to trauma, that it's measurable when there are historical factors happening in our society, that it affects babies and mothers. And I'm going to take that information and integrate it into my teaching. Thank you so much.
Absolutely. Well, thank you so much for appreciating it and spreading the information. It is just like you said, there's no way to address mental health in the community without addressing racial and immigration stressors as well. It certainly affects people's lives, even more so sometimes than the event of pregnancy is like the conditions in which you're pregnant and postpartum. So thank you for that. I'm looking in the chat to see if I saw any other questions. Oh, someone asked a question about if folks have a history of bodily trauma or, and I know that some folks have to log off, so it's okay. And there's a recording, you'll be able to catch the end if you need to. The recommendations for birthing people navigating pregnancy and preparing for birth if they have DV and bodily trauma. I really think that most people would benefit from a doula, a trained labor and pregnancy and postpartum support person. I especially feel like it's imperative for people who have a history of trauma. Pregnancy, particularly childbirth, can be really triggering for folks because of the activity of their reproductive body that has to be engaged with the healthcare system. They're asking you, open your legs. I need to see this. I need to put my hands inside of you. I mean, it's pretty, we sort of like go in as though it's like a normal thing to do, but we're really asking people to be extremely vulnerable to strangers often, who are their doctors or a nurse or the local family practitioner who's at the clinic for the day, to be fully exposed in areas that might be triggering. And so I would say having conversations with people to prepare them for their exams and to prepare them for labor is important. Doulas are often going to be checking in like they would be cued into that, especially if they're very experienced. But a therapist, a case manager, a people navigator, a CHA, like a lot of folks could be able to sort of have these sort of like conversations like about like the preparation, and is there a need for them to have a conversation with their therapist or a therapist beforehand or after, and most importantly, to have a conversation with the provider, the nurse, for them to have a sense of advocacy around, when I sit here, I'm still autonomous. I need you to tell me your name before you touch me. I need you to ask for my permission before you do anything, right? Like really teaching like self-autonomy, which is a lot of things that the doulas do around like birth advocacy is really important, because people tend to, if they've had trauma that way, lose a sense of autonomy and like a sense of that they have a right to say no, that they have especially when you're dealing with like the power dynamic of your doctor or like the nurse and your baby, and you're like, oh, well, if this helps the baby, even though I feel really uncomfortable and I feel like I'm, being assaulted here, I'm gonna like just letting them know that they never have to feel that way and that they can go through whatever they need to with support and care and with gentleness. And if the providers are not accommodating, to change providers. And we do a lot of advocacy for folks around really having good match care. But often if providers know, they can be sensitive. And so usually it's a lack of their awareness that there's a history, because early childhood sexual trauma doesn't necessarily come up in conversations when you're doing prenatal care, which it really should though. And I do a lot of training with them about like, yes, you should ask that so that you know how to support people. So that's a really great question, Heather. Thank you for that. We will send the frontline doula information. And the last thing that I saw, a person was asking the best way to practically bring up concerns for suspected PMADs in an empathetic way, if you're not a diagnosing practitioner, but someone supporting. Normalize, normalize, normalize. I would say, it's really having a baby and having, you know, a new infant, being pregnant at this time on this planet in this country is difficult, challenging, and potentially like offsetting for anyone. I often tell people, you know, I give them stories about what maternity care looks like in other countries, and then tell them like, this is what it looks like in Germany. This is what it looks like in London. This is what it looks like in, you know, in other countries. This is what it looks like in out of hospital birth. This is what like this is what like some options are, and this is what I'm hearing you say you're experiencing. We don't have a very supportive maternal system in the United States for anyone, not just for people of color, but for anyone. We don't have protections around not going to work early. You know, people are still bleeding postpartum and still being forced to go to work, or they'll lose their job and they lose their income. And we don't have protections, you know, for birthing people in this country the way that most first world nations do, and many non-first world nations, quote unquote, do. And it's why we have all of the disparities that we have, or definitely contributes to it. So I tell people that, like, it's pretty expected that we're going to have a certain percentage of people that have maternal mental health challenges and have like strong disorders, because you're not starting off with a normal baseline. You would have had chronic stressors that we shouldn't have, that, and as normal humans in the world, the industrial system, you know. So I just really try to educate people on like why one.
Yeah, I think she is frozen. I thought it was just me, but I think Dr. Pepper has frozen. We'll wait for her to come back and see if she can unfreeze herself. But if not, I do want to thank everyone for joining us today. If she's unable to hop back online, oh, she left us. Wanted to thank everyone for joining us today. Like I said, there'll be an email with all the resources that she is making available for us, and a link to the recording that you can view, and also CEU information. So that's it. I don't know if we want to wait for her to hop back on a couple minutes. I'll probably give everyone a couple more minutes to stay on and see if she joins us. But otherwise, thank you so much for joining us today.